Welcome to session 9 of our PCMH Learning Collaborative. As always, please put your phones on mute when you're not speaking and don't put your phone on hold. Today's objectives are introductions, a report from Amy Ollinghouse, a presentation from Community Care of North Carolina with Dr. Wegner, a presentation from Dr. Kurt Patton, a review of the next steps and 12-month requirements with Dr. Crow, and we'll see if anyone has questions or other thoughts. Support is provided by Arkansas Medicaid, and a quick roll call. I'm not exactly sure who's on here. I know Dr. Crow is on here, and I'm wondering if Dr. Davis, our president, is on here. And I can go through this quickly or come back to this in case people have not joined. Amy, are you on the call already? She might not be yet, so and I will look on my screen as far as which practices are on the call today. So Dr. Wegner, if you'd like to go ahead with your presentation, that would be wonderful. Thank you.
Great. Yeah, Kristen, can you hear me okay?
I can hear you fine. Can you hear me okay?
Okay, so I'm off-site today, and I'm using a regular telephone in the hotel lobby, so I apologize if there's some interference. And Kristen, you're going to turn the slides for me, right?
Yes, I'll turn the slides.
Okay. And to make sure we're on the right one, slide number 2 is the goals and vision for Arkansas Community Cares. Is that what you have, Kristen?
I'm sorry? Sorry, Dr. Wegner, can you hear me?
Yeah, I can hear you now.
Okay, yes, so, we're on the goals and vision slide. Okay,
great. So I was having a conversation with one of your physician members a few weeks ago, and the fellow was telling me that, well, we belong to this ACO from, I can't remember the name of the system, Mercy. We belong to this other one, but they're all connected to a hospital or an integrated delivery system. Wouldn't it be good if we could have something that was more physician-oriented? And that's exactly what we're trying to bring to our Arkansas model. We're entirely provider-driven. We want to work with the provider organizations. We want to build something locally. And the biggest focus will be on the care coordinators because that's what's in our contract. But what we want to do is try to build some organization, and then if it's self-sustaining in a couple of years, then that's great for us. We want to leave that there and move on. So the third slide, Kristen, is about the medical home, and I'm not going to go into that because you have covered that pretty adequately already, Dr. Crow. So I'll go to slide 4, which is the CCN clinical initiatives over the last 15 years. And Kristen, interrupt me if something doesn't make sense in terms of the slide numbers.
Well, everything's good.
Okay, so the core initiatives over here, the ones that make the money, save money, are transitional care. We'll go into a little bit about that later on. Work on the ED super utilizers, complex care management, and a lot of it about pharmacy, medication adherence, formula adherence, and then med reconciliation is very important. Now I'm going to kind of just lightly go over the chronic diseases and the behavioral health, but I'll focus more on the pediatrics since that's whom I'm talking to. And, you know, it started out in asthma. That was the easy one about 10 or 12 years ago. Obesity is now the latest one. That's much tougher, obviously. ADHD medications. We had led a project called A-plus kids that worked on antipsychotic reduction and had a lot of good results with that. Sickle cell, foster child, medical home, oral health, working to improve EHRs, and then finally we're working on a pediatric accountable care organization in North Carolina. So we also have pregnancy medical home, which really does affect pediatrics because those big money losers that end up in the NICU are very important. And then QI practice and support, which is what you've been working on. Slide 5, this is the transitional care results program that we had. Initially, some of our networks got involved with the Medicare transition program, and that really drove things because the hospitals started getting concerned about their readmissions and that they wouldn't get paid for those. You know, those rules have not been formalized in North Carolina Medicaid yet, but still we gain a great benefit by working on this. The payoff is for every 6 interventions that we do with these high-risk patients, we prevent 1 hospital readmission. And you can just do the math, simple math, and see how significant that is. Next slide would be slide 6. And I'm this is the last slide on North Carolina, just to tell you that we've been evaluated by several independent consulting firms that we didn't even hire, the legislative hired, to see if we were doing our job. And the one we cited here is one by Milliman, and it would save nearly $1 billion in the 4-year period from 2007 to 2010. So slide 7 is what's going to work in Arkansas. And so here's slide 8 is going to be what we've done already. And we have a new program director. She is on site in North Carolina right now, Susan Beasley. And she'll be there for a few days in training, and then she'll has an office in Little Rock. And Kristen and Amy, I'll be sure and introduce her to you. The other team members are Angela Floyd and Denise Levitz, who I believe are on the phone. And we hope to hire care coordinators in the community. We looked at where the practices and the patients are, and clearly there's lots of areas that are not going to be well served with because they have low density populations. And as part of our program, we will provide initial and ongoing comprehensive orientation and training. So slide 9 is our launch, and these are the activities. Much of this is dictated by the Arkansas Medicaid program, and the initial ones are things that I know that you've worked on for some time, but still it's important to evaluate because some practices, particularly those in the rural areas that are small, have not been able to work on these issues. But we'll start with an initial practice assessment. We'll work on population management readiness, ability to manage high-risk cost patients. We'll assess the practice EMR. And I know some of these things have been done and there won't be duplications, but we'll also see how the practice uses the provider portal. And on slide 10, we will assess how the practice implements a high-functioning healthcare team, what the role of the PCP and staff is, what the role of the family is, and what community resources are available as well. And then develop a practice-specific plan that will identify and manage high-risk and high-cost patients that throughout the whole population, not just the ones that are in the office. And assess and implement practice workflows to support the management of the high-risk patients, and then we hope to coordinate and align with other PCMH support systems. The care coordinator. This is slide 11 now. The care coordinator will prioritize health goals and time frame for each patient, develop care continuity, care transition, transportation plans, identify community resources, identify a wellness program, develop and monitor medication adherence. That's usually more of a problem with adults, but certainly asthma might be appropriate. Coordinate care across different providers and settings. You know, the transition from Arkansas Children's Hospital back to the practice. Sure, information is documented in the EMR. Slide 12 would be continuation of, well, that's such, well, let's see. Very similar to the one I just go over, so I'm not going to go over the details of it, except so that the plan will have all of these elements in it. Very thorough, I think, depending on the risk of the patient. When we really know that many of these complex patients have psychosocial issues, behavioral problems, cognitive functions, can they read, what their activities are, and then what resources are available for the caregivers. Slide 13 is communication and education with the care providers. They will coordinate what they do with the practice so that it's pretty much seamless. They'll identify and develop medical neighborhood partners, develop ongoing population health processes and procedures for their patient populations. Slide 14. So the communication with the care providers would be, again, cognizant of the health literacy issues, promote symptom identification and self-management for the patient, avoiding triggers or stresses, such as in asthma. In some of the older patients we'll be talking about, and some of the younger ones also, as far as asthma, as far as obesity goes, motivational interviewing techniques, promote medication and dietary adherence, promote physical activity, promote appropriate use of medical resources, and conduct home visits. And as you see all these are things that as practicing physicians, we just really don't have time to do all these, and that's what a care coordinator is going to help, how they're going to help us. You know, slide 15 is the design of the program by the Medicaid agency. They gave us some upfront money to set up the program, and then it's dependent in the long run on using care coordinators that are trained by us, that could be in the practice depending on the practice size, and then the payments would be made back to the new group that we've set up. And as you see, they set the amount of $3 per member per month and $2 per member per month plus 1/3 of the shared savings. And as we've spoken before, that eats into a lot of the money that comes to the pediatric practice. And it could be that in the future we can work on that, because the Medicaid people admitted they forgot to risk adjust the care coordination. They risk adjusted the amount that goes to you, but they didn't risk adjust the amount that would be needed for care coordination, so that it's the same for children as a lot of for children practices where there's a lot of well children, as it is for an adult practice that has a higher ratio of disabled patients. And so slide 16 is, we obviously have to create something that's a win-win-win for everybody. I think Medicaid believes that they're making sure that another part of their plan, care coordination, is put into the whole big plan of practice transformation. And the providers, we want them to feel supported and value the roles that their care coordinators are able to provide. We want them to be a part of the healthcare team and then look out for the medical neighborhood. Those are the patients that are not in the office every day, that are the ones that are going to the emergency room. Obviously, we need to work on quality metrics and benchmarks that are set by the practice and the group. Increase patient and physician satisfaction, and a win for everybody. So overall, we want to try to create a group of people that's provider-led, who will look to bring concerns of the Medicaid population. And I really think that's important that family medicine, adult physicians are involved in this as well, because Medicaid has peculiar issues about the way it treats its population, different rules, and so there, even though the ages are different, the diseases may be different, there's a lot of overlap in the program initiatives. So, and then again, as I said earlier, once it's sustainable, we want to turn it over to Arkansas to run. So that concludes my presentation, and we've had a conversation with several people there, and I know some of the issues. It doesn't seem coordinated with everything that you've looked at so far, and we're trying to work on a way to get everybody to the table. So any questions? Dennis.
Hey, it's Dennis Quo. Thanks so much. I appreciate your coming back and visiting us again. And what are what's your thoughts on for practices that are interested in working with this group? I mean, you mentioned the timeline on on hiring and such. What's the latest on your sense on when practices would be able to approach and say, hey, we're interested in contracting with this new group?
Yeah, I think we're going to be ready very soon. We have to get enough people together to make sure we can hire a care coordinator. But Susan Beasley will be there by the end of the week, and she is already receiving notes of interest and going to be calling on practices. So we'll probably try to send out another notice to through your pediatric group and send to your members saying, here's her name, here's her number. If you have an interest, please call.
And for folks on the call, this is we wanted to create the opportunity for you to be able to ask questions about what this would look like for your practices, how it might look for a practice, for a patient in your practice or several patients in your practice. And Stephen, do you have any thoughts you want to share on that? So, for example, one question I would always have is just to ensure the experience and the applicability of, say, a child who lives in one of our outlying communities. Do you have any thoughts on that and how it would work if you have a practice who are enrolled? And the converse for practices on a caller, what are your questions about how this would look like in practice?
Well, despite all of our efforts to make the transition seamless from your big hospitals to practices out in the rural areas, it just doesn't happen as well as it should. And we, in fact, have a CMI grant that works on that very issue of how do we even co-manage some of these really complex kids that have medical needs that are only going to be met by some specialists in Little Rock, but they live in a town maybe an hour or two away. How do we coordinate that? How do we communicate? And that coordination, I think, that improvement in that coordination has lots of opportunities for improvement in value to the patients and in particular to the families as well. So the answer is yes, we want to work on that. We've got some experience, and I think that an organization like this would be in a superb position to handle this transition from one area to another, so that they really go across the normal physical boundaries.
Folks on the call, questions? Questions about the program, questions about the opportunities?
Well, I would certainly ask that if there is any questions that that contact Amy or Kristen, and we'd be happy to respond. And we will get a mailing out very soon to everyone that we can. So thank you, Dr. Quo.
Hey, thank you, Dr. Wagner. I very much appreciate it. Kristen, I'm going to turn it back over to you.
Okay, thank you again, Dr. Wagner. And we've asked Dr. Patton to introduce himself and talk about his PCMH journey, because he always has a lot of great information to share. Dr. Patton, would you like to speak for a bit?
Yes. Can I verify that you guys are hearing me okay?
Loud and clear.
I am.
All right. Good deal. Well, some of you guys know me, others don't. I'm Dr. Kurt Patton. I'm a pediatrician, member of the AAP for the last 33 years. Been in practice in East Arkansas in what most of you would call the Delta for that period of time. I am in a clinic, East Arkansas Children's Clinic, that currently consists of one other physician associate, a physician named Dr. Pablo Almuna. Y'all may have seen his name on referrals to Children's. And then I have 3 nurse practitioner associates who do probably as much or certainly equal amount of work as our 2 physicians. We have an office staff of about 9 people, 3 nurses, and about 5 office people. But having said that, I'll go ahead and jump into what we've experienced with the PCMH initiative. I think some of the challenges that we have with a clinic of our size away from urban areas is that we do not have a full-time designated office manager. So the way we try to overcome that is we budgeted some of my time and my lead administrative assistant's time to deal with the PCMH process. I'm fortunate that I have just enough associates that are actually seeing patients most of the time to do that, but in talking to other physicians in our area who are solo or don't have other associates, they're really struggling and dealing with this, and that's one of the major issues with small clinics dropping out or not participating in the PCMH program. The second challenge that we've dealt with is getting the buy-in from all of our providers to this process. I think we are all committed to the idea of the quality that can be achieved through it. We've always sort of tried to follow the primary care medical home model even prior to the Medicaid initiative, so it's not alien to us, but certainly with the extra funding and some of the guidelines we've been given, we've gotten more serious and more detailed about it. One of the good things about having
Kurt, there's a lot of background noise. Is that yours or is that someone else?
I think it's someone else's. It's not coming from my end.
Could everyone make sure their phone's on mute?
All right, should I proceed?
Let's give it a shot.
All right, okay.
Thanks.
I'm not sure how much y'all heard. I will not double back completely, but let me just get back to my second point, that getting buy-in has been an issue, but we have overcome it. Part of what we've done is done a small amount of we've shared some of the funds from the initiative with each provider to sort of give them a carrot to participate. The quality improvement has always been a goal, and so they're anxious to do that. One, the good thing about my nurse practitioner associates, a quality improvement project is one of the requirements of the nursing board in order for them to get prescriptive authority renewal each year. And so we are using the quality initiatives through the PCMH project to qualify as their quality improvement project. So that prevents some duplication and, again, gets them very enthusiastic about doing it. My third point, I guess, when it comes to using these additional funds, again, we have budgeted a couple hours each week of my time and the administrative assistant's time. Basically, in a small clinic, I'm paying myself not to see patients. And so I am the practices consultant. Again, that only works for me as a small, medium clinic. It may not work for a solo practitioner in a rural area. It may not work for docs that just don't have the time. But that's what's worked for us. We've also purchased technology such as e-prescribing. We were headed that direction anyway because of meaningful use, but meaningful use in our practice is about 6 months ahead of the PCMH initiative, so there is some overlap, but we have been doing that with some of the funds, getting the prescribing technology together. We've also added some laptops for clinical staff and make sure that everybody has equal access, whereas before we didn't have funds to dedicate a single laptop for each individual, but we're doing that now. In addition, we're using some of the funds to pay for meeting travel expenses when we go out of town. We went to the AFMC meeting in Pine Bluff last month and heard some presentations there and basically used some of those funds for travel expenses. I tell you what we haven't done. At the present time, we've not elected to use outside consultants for various reasons. What I'm thinking of, I think we refer to as Qualis, and the reason we had not used them initially was because we were under the impression that we would have to pay them a fee, which would eat into our incentive funds quite a bit. And then when we were re-educated that we could obtain them at no cost, then we had pretty much done a lot of the work that they were going to do. So we've not used them because of that reason. I know some of you have, and I've got good feedback. We would still consider using them if we need to meet 12-month standards and on and on. The presentation we just heard, I think, is very important. And if I were in a group that had, you know, maybe 10 to 15 pediatricians like some of you guys at Little Rock, and my caseload per pediatrician was 200 to 300 to 400, then the numbers might work because, again, most of your clients probably have insurance. On the other hand, in my practice, we're all Medicaid. And so for us to pay really a good part of our per member per month initiative funds would pretty much remove them, and so we're struggling with the concept, although I have no problem seeing the quality and what could be obtained by paying for the care coordinators that was just outlined. So we haven't ruled it out yet, but again, in a smaller practice that's all Medicaid, we would be paying most of our funds that we would get just for that reason. I don't know what most of you guys are getting per member per month. I don't mind sharing that we're getting about $4. And so again, at a cost of $3 per member per month, that would pretty much wipe that out. So I don't know, maybe our per member per month is lower than it could be or should be, and I'll need to look into that. But again, that's one of the challenges with the care coordinators, although it sounds like a great program and I would sure like to do it if we could afford it. And then the last point I'll make is with our care coordination plans, for those of you that have looked at that before me, you're probably way ahead of me, but again, because we're smaller and only got started about 6 months ago on PCMH, we are writing them as we speak. The two options that AFMC proposed were the standalone plans, which our software, which is eClinical, would allow, but after going through it, we decided that doing the plan within a visit made more sense to us, followed our thought processes more naturally, and so that's the method we're using, and at least the initial plans we think are good and will meet all the criteria, but we're still waiting to hear from AFMC as to whether they'll accept them for what we're doing. So I think with that, I'll wrap it up, and there's time for questions later, but if there are any specifically for me, I'll take them now. All right. Well, thanks very much, guys. I'll be still listening.
Chris, hey, thanks so much. I really appreciate it. And I think it's great to give your perspective, particularly you know, as a smaller practice. I know that that's been an area of question for a number of folks that we've had on the call. And what I'd like to do is have folks be able to network with each other to also know who the contacts are around the state so that we can refer folks to one another if they're looking at an issue that's for a similar sized clinic. And for folks, we will be asking folks to just talk about more about their experiences as we go along, and that'll lead to a lot more discussion. Kristen, I never managed to get connected to WebEx, so I'm going to have to go on the slides that I sent you. Are there any other differences in between the ones I sent you before and the ones that are presented up on the screen?
No, except for we had an extra slide on the care attestation, so I took one slide out, and I'll let you know if you get to that, or you'll see it. But right now I'm on the slide that says it's December. Okay.
So let's go to the next slide and just talk about what's going on right now with changes for 2015. And I've got a few updates that we can go through before we close the webinar. So the latest I have on changes for 2015 and are that at this point, folks have re-enrolled, and what I have heard from folks is our colleagues at DHS is that you know, the re-enrollment rate has been very high, and there's been a number of new practices that have joined on. There have been a small number of practices that have dropped out. But those are practices that you know our colleagues at DHS and AFMC have noted. You know, once they got started and decided not to continue somewhere along the line. But what we have also been told repeatedly is we want to ensure progress no matter what state of change that you're at, and so we'll always continue to work with you on whatever state of change. And as long as you are continuing to make changes in your practice delivery, then we're all going to be fine. So the first is that there's one more milestone that's being added that we have to attest to, which is that in the next 12 months that we have to be able to show some ability to extract data from our electronic health record. And what that means is that population management. So, let's look at some sort of data report on our entire patient population. And I believe that most of us can do that already, but if not, or if there are questions, please let us know. We can discuss that further. Another area is that there are some targets that are expected to change based on performances from this year, and I did want to mention that some of them are expected to change. One is that the shared savings metric is that the ADHD for ages 6 to 12 seen within 30 days, that is expected to go from 25 to 50% of children. And then the process metrics for maintaining practice support is that the care plan attestations is expected to go up to about 80%. Primary care 2 visits for high priority beneficiaries has to go up to 75%. The inpatient follow-up within 10 days metric is going to go up to 40%, and then a non-emergent emergency room visit is supposed to go from 50% down to 33%. So what we have seen is the medians for what practices around the state have been doing, and they've just adjusted these metrics to reflect more of what the practices are doing around the state. So we're just they're moving the bar a little bit. And one question that I think, Kristen, do you mind talking about the emails you sent me this morning? It was a question I had raised. I haven't had a chance to read through it all, at length, but the question I had was, for practices who are not meeting the process metrics, so you have to meet 3 out of 4 process metrics in order to maintain support payments. At what point would remediation be offered? And Kristen, do you mind talking about that? Because I haven't had a chance to read through the email in detail.
Sure, and actually I'm going to go to the email really quick just so that I know that I have this correct. Let's see, okay. What they were telling us was that regarding the metrics, okay, practices will be notified on the Q2 2015 report that comes out on 6/1/15 of their results for the 2014 calendar year. A practice that did not meet metric targets will have to remediate performance before the end of the second full quarter after the date the practice receives notice via the provider report. And this means they will have until the very end of 2015, 12/31/2015, to remediate their performance. I'm hoping that makes some sense. Does anyone have any questions about that?
So what I'm seeing on that is that, let's say you are not meeting, the process metrics because you're meeting 2 out of 4. Your non-emergent ED visits are, let's say they're 55%, and your inpatient follow-up is around 20%. Because those metrics are 12-month rolling averages, there's going to be a period of time before the data reports that you get start reflecting the changes you make in practice. Because those data reports right now are lagging about 6 months behind when we see those data reports. In other words, when we get our December data reports, which are due to come out sometime this week, when we get our 12-month data reports this week, that's going to reflect data that goes back to July of 2013 up to June of 2014. So you're not going to see a whole lot of change in the meantime. And what this email is saying is that they're going to be looking at those metrics beginning in June of 2015. So if you are not meeting those metrics in December, just keep working on what we need to be doing for those metrics between now and June. And then if there is a remediation that needs to be made at that point, then we will address it then. The other thing is that remediation for process metrics is a 2-quarter remediation process. And that's very different from the 1-quarter remediation that happens for anything you attest in the portal. So, you know, the 12-month activity metrics, you go into your 12-month activity metrics, which are due at the end of this month. You fill out your survey. You attest to the electronic health, the technology adoption that you're doing. If there's a remediation that's judged to be needed, then you've got 1 quarter or 3 months to submit a remediation plan. For the process metrics, you'll have 2 quarters, so that if you get a remediation request for, let's say, a 10-day inpatient follow-up and non-emergent emergency room visits, you'll have until the end of December of 2015 to submit and address the plan. Are there any questions, comments, reactions? Okay.
Dr. Crow, this is
Yes.
Dr. Patton.
Hey.
Let's see. You said you cannot see the slides we're looking at?
Well, I've got a copy of the slides up for,
Okay.
that I have. So.
The slides you got changes for 2015. I just need to clarify under process metrics. You got HPBs equal care plans. What does HPB stand for?
Okay. So HPB is high priority beneficiaries.
Oh, okay.
Right.
Okay.
Gotcha. So the kids that we have to attest on care plans on.
Yes, I got you. I'm clear on that now. Okay. Great.
Sorry, to save a bullet point, I grouped the care plans and PCP visits onto the same bullet point, so I apologize.
No. We all know the most important thing is medicine is get your abbreviations down. I'll have another one in just a second, but I'm going to put it on pause and see if someone else has one.
Okay. Other questions from folks about the changes in 2015? Dr. Patton, go ahead.
One of the things I didn't touch on, but that those of you that are having to do this understand, is we're sort of in a we're sort of at the edge of the earth in our area with the PCMH, because none of our practices are big enough, even though they're all Medicaid, to qualify for the minimum of $5,000 to have our own risk share. So we had to make a decision a couple of weeks ago of either to go in the statewide pool or pool together. 5 of us in town here did decide to go together. Our practice is the largest contributor of the caseload, and then there were 4 other family doctors or internists who had about 400 to 500 each that threw in with us. However, how will all of these shared practices, since I assume that the process metrics and the shared savings metrics will be directed toward our little mini pool, how will that be communicated to us as a group? Will we all get the same report? Do we need to be on the lookout for it? I'm talking next year. I'm a little bit confused as to how these small shared pools will be communicated with.
There are a couple of practices. I know there's several practices. Are any practices that are currently on part of the pool from this year that want to comment? Dr. Patton, I think we can investigate that answer and get back to you.
Okay.
I don't have an answer from my end because I'm a part of a practice that's not pooling. I know of several practices that did pool this year, and I think we can get feedback directly from them.
Okay. All righty.
Kristen, if we can note that, let's follow up on that. I can follow up with you about the practices that I would go ask. I know of several practices that have pooled.
Yeah. Okay. Well, our 5 practices are having our first organizational meeting locally tomorrow. I don't need an answer by then, but I know that will come up as we start talking about some of the things on your slides today,
Sure.
which, again, are very helpful because, you know, again, as a smaller practice, I feel like I'm always kind of behind the curve in learning these things. So these process metrics proposed for 2015, I think, are very helpful. We can take our current report, see where we stand, and decide how to act. So knowing them ahead of time is a big plus for those of us that feel like we're behind the curve.
I have one question for you. Are any of your practices that you're pulling with, are they in it for the first time this year?
Are any of them what?
Did any of them are enrolling in the PCMH program for the first time next year? Or
no.
Were they all enrolled this year?
They were all enrolled this year.
Okay. One thing I didn't put in here was that practices that enroll in 2015 have to meet all the metrics. Have to meet all the metrics. The metrics that we have to meet for those of us who enrolled in 2014, and we've got 24 months to meet a certain number of metrics. Practices that enrolled in 2015 have to meet all of them by the end of the year, so that everybody's caught up. And that's something that folks need to know if they're enrolling this year.
Okay.
Okay. Okay, Kristen, let's go to the next. The next slide is just a summary slide for the required portal activities. And I'm assuming that folks are working on their 12-month activities. We've sent around the short survey, a written copy of the survey about the medical neighborhood. If you haven't yet, the heads up is that not really all that short. It's now suggested that you leave at least 30 minutes, but I would suggest that you look at it beforehand because to really accurately report those findings on your behavior, on that survey, you're really going to need to look at it before. Rest of those 12-month metrics are, in my opinion, pretty straightforward. But I do want you to hear from us that definitely look at your survey before you go into the portal. And if you need another copy of the written copy of the survey, let us know and we can send it to you again. Chris? Okay, so the next slide I have is just the same thing. It's just a 12-month requirement, and just make sure you do a survey properly. The next slide is a data report, and the last I heard about the December data report is that it's supposed to be out in 2 days. So just look for it in the portal, and again, pay attention to the metrics that are 12-month rolling averages, and that we won't expect them to change all that soon because you're still looking at those 12-month averages continuing to have data that dates back to the last half of 2013.
That's why I sent you that.
Okay. Kristen, next slide. The care plan attestations is just the opportunity for, if anyone is on the call that wanted to share their experiences on care plans and attestations and AFMCs, any experiences from audits that they have, or any tips or pointers that folks have learned about the care plans. I wanted to just open it up, and if there's no feedback, or if I don't want to put folks on the spot, so I won't call anyone out. But I figured I'd ask and see how folks are going. I will say that we haven't gone through any audits over at Children, so I don't have anything to add there, but I know some folks have gone through some audits, and there are probably some things that can be shared that we can learn from. Anybody have any comments or feedback that they want to share? I'm hearing some background noise. Kristen, the rest of the slides are really, the rest of the slides I have are the survey and the care plan attestations. If there are no other comments, I think we can close. Are there any other slides that you have that you've added?
Dennis, I did have a question.
Yes, go ahead.
Hey, this is Dr. Patton again. Regarding the survey, I have done a preliminary look at it, and one question that I know my providers are going to have when we fill it out is that many of the questions ask generically, like, how are you doing with referrals to endocrinology? You know, do you feel like you've got access? And then another one, how do you feel about access to orthopedics? I'm struggling with telling my other providers how to answer these questions, well, not how to answer them, but how to approach them, because there are so many different answers for each one. For example, the delay in getting someone into children's endocrine is quite long.
It is. But
to Le Bonheur and UT, it's even worse. Then an orthopedics, to a local orthopedist, it's not too bad. It's within a day or two. But to children's orthopedics, it might be 3 to 4 weeks. So we're struggling with how to answer some of the survey because of our different situations and even within our particular PCMH, we have different answers depending on who you're talking about. Any suggestions on how to do that?
Yeah, I have some suggestions. I can give you some feedback from what I've heard about the survey. The survey is really meant to just it's more of a data gathering about how things look in your practice, and it's not something that's going to be audited or double-checked or evaluated. So, you know, the question says, what range best describes the average number of days for referral? So it's not looking for an exact number. And, you know, we'll tell you not to try to sweat those details much. In the case of, and you mentioned at endocrine that the wait was pretty long at the 2 different institutions you refer to, one being Children's here and being Le Bonheur. And I think that can pretty accurately be reflected. I know, for example, that there's a more than 3 weeks choice. As far as the average number of days for referrals in orthopedics, you know, you said that there are folks where it would be short and there are folks that it would be longer because it depends on where you refer to.
Yes.
Depending on the situation, depending on the age. Personally, I pick a middle ground, but I think if your patients predominantly come to Children's and the wait's longer, then I would pick the longer one. I think it's really just to give DHS, our colleagues at DHS, an idea of what are the challenges that you face in getting our kids the specialty access that they need. And if the majority of your patients are having to wait more than 3 weeks for a particular appointment because it's available at Children's, then I would answer that way. Does that help?
Yeah, that makes sense. A second question is regarding this small pool of providers we put together. It's going to be challenging because we're the only pediatric clinic. Right. And the other 4, like I said, we have 3 family doctors and 1 internal medicine who is participating because he accepts kids above the age of, I think, 8 or 10. So anyway, he's got some teenagers. But the thing I'm struggling with a little bit on this is how we're going to I know what it was. I'm sorry. And this may be more for Kristen than you, Dr. Kuo, but, you know, I don't think that any of those other 4 providers are participating in any of the webinars or any of the other educational opportunities that AFMC is offering. Maybe 1 is, but certainly not all 5 are. Kristen, I assume that these webinars are open to non-AAP members.
Yes, they're open to everyone.
And I think they're archived too, aren't they?
Yes, they're all on our website. mostly recorded. Some are just the slide decks. So if you'd like to share, just have people go to our website under webinars, the webinars tab, and they can look at any of these slides or the recordings of these webinars just to learn more information about things. And I think you can do the same at AFMC for theirs.
Okay. All right, just verifying, because it's looking like I'm going to end up being the point person for our group, even though I didn't necessarily seek that position. I think that's all I have, Dr. Quo. Thanks very much.
Hey, thank you. And are there any last questions since we're just about done?
Dennis,
yes.
This is Cheryl Arnold. I do have one question, and others have asked me this question, so I know there are other people thinking about it.
Okay.
With this, since it was sort of mid-year before everybody sort of got on track with their care plans, and some people are still struggling with them.
Yep.
And our, of course, most recent reports lag in time. It's hard to know what your true score is on those because we look at it and we can tell how many we've submitted to the portal, but our scores don't reflect that yet.
Right.
Are they going to be looking for 2 care plans or for this time, or will it maybe be that you've gotten started on it? Because some patients haven't been in twice since this has been required, or since everybody's gotten rolling on their care plans.
Yeah, so the official answer we got for this year was to initiate and update it once. So, and I do, and you know, in the portal, it only says to attest. So, and I know that's created some confusion. One bottom line is that we're not going to be, we now know that we're not going to be, as far as assessment and remediation and such, that's not going to be an issue until the end of next year. So I don't think that's something we need to worry about. And but the answer for this year was that we attest if it's been created and been updated at least once. So I mean, you're right. There's no way that you could update it twice because we only really just got started. And I think that given that we're looking at remediation not being an issue for this metric until the second quarter report in June of next year, that we try to get them in, and we try to get them at least once for this year, and then we do the cycle again in the next 6 months, and then we go from there. Does that answer your question?
Yes, sir. Thank you very much.
Okay, you're welcome. Okay, it's 1:15. If there are no other questions, then we'll close, and I want to wish everyone a very, very safe and happy holiday. And if we don't hear or talk to you between now and the New Year, Happy New Year, and we'll talk to you all soon. Thank you very much, everyone.